Dr. Bhaskar is a cornea and refractive consultant in Shankar Netralaya, Chennai, and he'll be talking on MMG in SJS.
Very good afternoon, and I would like to thank the AIOS organizing committee for giving me the chance to be a part of the Q&A session. So basically, when looking at an acute SJS, it's a severe cutaneous adverse reaction, and we do know that in the acute phase, so in the acute phase, there is a definite role of amniotic membrane transplantation, and you might have to start the patient on systemic cyclosporine or systemic steroids. In the chronic phase, you have various manifestations, but the one manifestation which seems to make a significant impact on long-term vision of these patients is lid margin keratinization, because that causes blink-related microtrauma, leading to a constant damage to the ocular surface. So this is how a lid margin keratinization looks when it's very severe. And if you're looking at incidence, in our study we found almost about 70% of patients had lid margin keratinization if you actually go and look for it. And you can actually see that the area of the keratinization actually corresponds to the area of significant staining on the ocular surface. Between the upper lid and the lower lid, because of the excursion of the upper lid is more, you will tend to have more of an effect if the LMK is more in the upper lid as compared to the lower lid. But sometimes it might be very subtle, where you actually just in a diffuse illumination you might not be able to see. If you stain with fluorescein, you will see it as a negative stained area, because when it assumes skin-like consistency, the fluid will not be on that area. So negative staining at the lid margin would indicate an early keratinization, and that's something that you need to address, otherwise you will end up with small perforations and finally an end-stage ocular surface failure. What are the treatment options? You have bandage contact lens, you have scleral contact lenses, you have the option of mucous membrane grafting, and sometimes you might have to combine both the mucous membrane grafting with a pros lens for better vision. What is the decision making which decides whether you would want to operate this would depend on the grade of the LMK, would depend on the patient's symptoms, the corneal damage, the surface keratinization, and if you're planning any intraocular procedure. In terms of technique, it's a fairly simple procedure, but you have to got to do it right. So you take lid sutures to get a good exposure of the area. You evert it over either two Wexel buds or two Johnson's buds, or you can take two sutures and evert it over the back end of any flat instrument. The plane of dissection is between the conjunctiva and the tarsal plate. So unlike what the oculoplasty people do in terms of the skin and the muscle on one side and the tarsal plate and the conjunctiva on the other side, we are basically dissecting between the conjunctiva and the tarsal plate. So the amount of tissue that you're removing is going to be much more thinner as compared to what we conventionally do with the oculoplastic surgeons. It's important not to damage the tarsal plate as much as possible, but if you have a lot of districhiatic lashes, you might want to include them in your dissection. The harvesting of the oral mucosa is fairly simple, where you need to take a little bit larger, because there is a tendency for the mucosa to shrink, and you'd probably, if you're doing a bilateral procedure, you'll probably need somewhere around a 40 centimeter by 10 centimeter width of the tissue, so that you can use it for all four lids as such. The mucosa, you can either leave it to heal by secondary intention, or you can suture it. We prefer to suture it so that the patients are a little bit more comfortable in the early post-operative period, and you can take a mattress suture, or you can take an interlocking suture, so that you are able to tightly oppose it. It's important to thin the mucosa, because the conjunctiva that you are removing is thin. The mucosa also has to be as thin, because you don't want it to be thick, in which case there will be an increased friction between the lid and the cornea. So you can wrap it around your fingers and just thin it out. And then you are placing it on the lid margin, you are suturing it at the anterior portion so that you can stretch the tissue nicely, and the posterior portion you can stick it with fibrin glue. Here it's important that your mucosa doesn't go beyond the area of defect, because if you have the mucosa going on top of the residual conjunctiva, you will have conjunctiva growing under the mucosa, which will result in a necrosis of your tissue. So your tissue that you're putting has to be slightly smaller than the bare area that you are leaving in the lid margin. The suturing is similar for the upper lid and the lower lid, and that pretty much is what you would need to do. And most times these patients are pretty comfortable post-operatively. You can actually leave the conjunctiva there, so you're sure that you are not going to overlap your mucosa with the residual conjunctiva. And then once you stick it with glue, When you are removing your speculum, you need to be careful that you don't pull or yank the tissue, because the fibrin clot can kind of get dislodged. So if there's any tag, it's better to just cut it with a scissor rather than try to just tease it with a spatula or an instrument as such. Sometimes when you are dissecting the upper lid or the lower lid, there can be a slight variation in techniques, which we'll see next in this. Yeah, so meticulous removal of the glue. And so here I am using the back end of an instrument. I've used 2 lid speculum. So this also gives you a good counter traction, so your bleeding can actually be reduced by just pulling the tissue up, so that there's a tautness to it. You can actually see the reflection of the 15 number blade under the conjunctiva. That tells you that you are superficial, and that's the dissection plane that you would want to maintain. And you can actually see that shining tarsus as you are reflecting the overlying keratinized conjunctiva. So for the lower lid, sometimes you can, if you feel that you're not getting a counter traction, you can start the dissection even from the conjunctival side. So once you make it, you can just do it like how you do it in SICS. You can use a crescent. Again, you need to see the reflection of the instrument under the conjunctiva to know that you are superficial. Because if you're going to use this way of dissecting it, it's very easy to actually go into the tarsal plate and end up removing a tarsal, which will actually cause a bit of an entropion once the surgery is done. And then you're making a groove at the lid margin. The incision side of the lid margin is just behind the meibomian gland orifice, and then you are removing off the tissue. So you have a bare area, you measure the area, and you harvest the tissue. If you are using the mucosa for, say, a surface reconstruction, and you want a very thin mucosa, you can again do a similar process where you are just using the crescent on the mucosal surface to get a thinner graft, so your dissection time becomes lesser. But you can't do it if you're doing it for all 4 lids, because it kind of breaks. So if you're doing it only for 2 lids, you can probably use this way, so that the time that you spend on thinning the tissue by wrapping it over the fingers is reduced. And if you have to combine it with the fornix reconstruction, instead of splitting the conjunctiva at the limbus, you can actually cut it at the lid margin, push that conjunctiva down, so that forms a part of the bulbar area. So you have a broad area on the tarsal surface where you can put a broad mucous membrane graft. So for any surface reconstruction procedure, you would ideally want both the surfaces epithelialized. So here you have a broad mucosa which is covering from the lid margin till the fornix, and here you have the conjunctiva which is going deeper into the fornix to get a reasonable depth. So with just that one surgery, without having to use amniotic, you are getting your fornix reconstruction and your lid margin keratinization both addressed. Post-operatively, we probably don't need any topical steroids. We normally remove the sutures by a week to 10 days time, and in fact by day 2, day 3, the eye will significantly quieten. This is a patient who was using contact lenses for the last 15 years, and she said that she could never open the eyes without a contact lens, and this is 2nd day post-op where she was comfortably opening the eye. You might even see an improvement in the ocular luster and the clarity as the friction component reduces. You can see the haze coming down, you can see the vascularization coming down post mucous membrane graft. This patient refused MMG when we first advised it. One eye was lost, and the other eye, when it got worse, we did it, so at least we were able to stabilize it in the 2nd eye before we lost that eye also to an end-stage ocular surface failure. Like I said, your mucosa should not be very thick. If you are making a mucosa thick, then the entire reason for which you are doing the procedure in terms of a blink-related microtrauma gets negated, because you are actually worsening the surface rather than improving it. Again, if there is a recurrence of the keratinization, you might have to redo the procedure. If the mucosa necroses off, and that will happen only if there is a conjunctiva which is growing under it, or your glue has not got, the mucosa has not got stuck properly to the base. So make sure that you stick it properly. Just a couple of seconds. Recurrence is easy to manage. Frequently asked questions. What is the plane of dissection? We've already mentioned that it's between the conjunctiva and the tarsus. Age limit, there is no specific age limit. Only thing is, if the patient has a recent onset of SJS, you will wait for the mucosa to heal, after which only you will take the patient up for surgery. Our youngest has been about a year. Whether local anesthesia or general anesthesia, we prefer general anesthesia if you're going to do all 4 lids. If you're going to be doing 2 lids, you could do it under local anesthesia. Size of the graft depends on the area of defect that is created. People do ask whether we are worried about rejection. Obviously not, because it's an autologous tissue, but what we are worried about is a necrosis of the tissue, because it has not been placed correctly. Complications: too thick a mucosa, recurrence of keratinization, or a loss of graft because of necrosis. Long-term results are pretty good. This was a patient whom we did MMG in 2006. and this is now almost, then she was wearing a Prose lens, and this is almost recently, about a couple of years back. So it's almost like a 14-15 year period, and she's now pursuing her studies. This was one of our patients in 2006, operated, he's studying, he's now in NASA doing some research work there. Thank you.
Thank you, sir. So one question for Dr. Bhaskar was that if you just mentioned about recurrence in cases of keratinization. So what is the management like? You do sectoral MMG or in those cases or complete?
You can do a sectoral, but the problem is wherever you have the edges, you will have a sliver of mucus, keratinization kind of sticking in. So if there is a recurrence, I would want to see if sometimes if your mucosa is slightly thicker, it probably helps you because the recurrent thing doesn't rub it. So I would want to still look at the surface. I would look at where the recurrence is. If obviously that area there is increase in keratin, increase in surface staining, that means I need to address that. I would probably put a broader tissue again rather than just putting a small sliver of tissue there.
Thank you, sir.
Any other question, comments for Bhaskar?
Generally a month is fine because the mucosa takes up in about 10 days time.